You're listening to the Pharmacy Podcast Network's exclusive coverage of the Cardinal Health Retail Business Conference 2017, conference and exhibition in San Antonio, Texas. RBC is more than a pharmacy business conference. This interactive gathering of pharmacy owners started in 1990 as a regional show and has since grown into the industry's largest trade show for independent pharmacies. While the conference location changes from year to year, the mission of the RBC remains the same: to help independent pharmacies navigate the ever-changing marketplace by giving them access to the best pharmacy business vendors in the industry. And now, here are your hosts of the Pharmacy Podcast Network, Dr. Erin Albert and Todd Eury.
Hey, Pharmacy Podcast Network. This is Todd Eury, founder of the Pharmacy Podcast. I'm here with my faithful co-host, Dr. Erin Albert.
Hello.
Welcome to RBC 2017 here in San Antonio, Texas.
It's a pleasure.
I'm excited to be here. We are here. We'll be with Sean Callinicos, Senior Vice President of Government Relations at Cardinal Health. Welcome to the Pharmacy Podcast.
Thanks very much, Todd. Pleasure to be here.
So, government relations in the industry of pharmacy, I can't think of something more out front, paving the way for what's to come for different facets of our industry and how important those government relations are to setting standards, policies, and procedures, and really opening up doors. So my first question is, Sean, just tell us about yourself, tell us about your background and what you do at Cardinal Health.
Thank you. I joined Cardinal Health about 18 months ago, run global government affairs. My prior background was working with Sanofi Aventis as a lobbyist for 12 years.
Okay. And
before that, on Capitol Hill and as an attorney.
Excellent. So Erin happens to also be an attorney, and I think you've always had different viewpoints than what I've had, because coming from a marketing and business development background, I'm not as, I guess, tapped into some of that stuff. So I'm going to turn it over to Erin for some of our first questions.
Yeah, so lots going on right now with the Affordable Care Act, or its demise, potentially. So where do you think federal government healthcare is headed at this point? And I know it's very smoke and mirrors at this point, but...
And today is a very pivotal day. Starting at noon, they're going to be voting in the Senate for potentially dozens of hours on their version of the ACA repeal and replace. I think, as we've all seen, they've had some difficulty getting their bill out. The House did it in early summer. It looks like where they're headed is a very narrow bill, what they're calling a skinny repeal. Repeals the insurance mandates on employers and individuals, sending it to conference with the House, which means this debate will drag out potentially into the fall, which is not anything the congressional leadership would like. They'd like to move on in the fall to taxes.
There's a lot of argument out there that innovation in healthcare really occurs more at the state level in the U.S. versus the federal level. What are your thoughts on moving maybe healthcare down to the state level? Obviously, Medicaid is a shared program between feds and state, but any thoughts on that?
No, that's a good question. I think over the last decade, the more and more paralysis you see in Washington, the more innovation you see in the states. It used to be it was the larger states like California would take the lead on policy, but now you're seeing a range of states take an active role. For example, Iowa has an innovative proposal to get a waiver from Medicaid if they don't get coverage in the exchanges. You see certain attempts in the states, in Ohio, California, and other states on price controls on drugs. I think that's a reflection of the paralysis in Washington, but new administration, some new blood. I think you're going to see some new activities, particularly the FDA commissioner. I think will push hard to have more marketplace competition from generics, particularly in the biosimilar space, where many would argue the EU has been more aggressive in licensing biosimilars.
When I think of reimbursement, and we think of standard reimbursement or today's run-of-the-mill, what I'm looking at is, as providers and obtaining provider status, there's going to be new opportunities that are going to open up for reimbursement for specific services that pharmacists are already doing, and they're not being compensated for it. So as someone with your finger on the pulse, what type of services do you see becoming reimbursable through CMS guidelines?
That's a very good question, because with the new administration, a lot of the proposals that was coming out of CMMI were thrown into question. I think the last administration, the Part B proposal they put out there was very controversial and created a lot of political backlash on Capitol Hill. However, I think the market needs for cost containment are still there. So I think CMMI still could play a potentially very helpful role in looking at some of these big programs. 340B and Part B are good examples. 340B, there are some proposals out there for dramatic cuts. I think that's the opening gambit.
That's what
I think
I'm
it's
hearing.
a long way to
Yeah.
go.
I'm hearing that there's like the coming of the end of 340B, and some people say that's not going to happen, and other people say it is going to happen. So yeah, expand upon that.
Yeah, that is, there are many of the pharmaceutical companies that feel that 340B has expanded beyond its intent, and that hospitals have expanded it unfairly. There's been some congressional oversight, but a tremendously difficult issue to deal with. There was administrative efforts with the so-called mega rule to limit the program that was then withdrawn. I think you're going to see more activity on that. I think it's going to take a long while, most of this year at least, to come at some sort of clarity on 340B. I think congressional activity is unlikely. The two sides are deadlocked. So I think, it will come from administrative activity.
So globally, the United States is not the best healthcare system out there. So what are some of the best practices that you've seen globally from other countries? Who's doing it right when it comes to healthcare?
And that's a very good question, and it comes down to, in many countries, and the U.S. is an example of this, we look at our healthcare system, there's certain parts that are very inefficient, very costly, but it's based on the culture and our history, and every country has that. For an example, in England, they have the NICE system, where they will evaluate cost-benefit on drugs very aggressively and often deny payment on certain drugs, either classified as lifestyle or end-of-life drugs that don't extend life beyond a certain period. It's an approach that would not be accepted in the United States. I think some other systems perhaps have been more aggressive on costs. The EU licensing biosimilars is a good example. And on coverage, most of the European countries adopt an approach similar to Switzerland. It would be government mandate with aggressive private competition, dozens, if not hundreds, of insurance companies competing for the same customers. But each country is largely dependent on its history and culture, and we're definitely, we have parts of the healthcare system here that are inefficient and need looking at. For the last decade, we've spent all the time on what has become the ACA marketplace. It's important to remember those only cover 7% of Americans. Most Americans still get coverage by the employer, VA, Medicaid, Medicare, and that's sometimes forgotten in this debate.
And there's many, I have a lot of friends right now in the pharmacy world who are getting ready to retire, and they're very nervous about it because they don't know what Medicare is going to look like moving forward as well. So.
And it may be a program that is expanded, for example, to from 65 to 55 to cover a lot of those young retirees or people who've lost jobs. Those are generally cheaper patients to insure than the older Medicare patients. Medicaid, obviously, Republicans in their ACA bill have made an effort to change the program, but it's run into a lot of political problems because of the potential loss of coverage.
Mm-hmm.
So we're all standing around with our arms folded, impatiently waiting for provider status to actually come to be. Which of the states, I know there's several, that have already recognized pharmacists as providers, as true healthcare providers from a reimbursement perspective? Which of those states are there that are actually, is it California? Who else?
There's a handful. California is definitely the lead. It tends to lead on a lot of these issues from sheer size, and I would say a very sophisticated legislative system based on the size. So California often tends to be almost the beta test on a lot of these programs. And I think we've seen that in healthcare. They had a major push, for example, last year to rein in prices with the drug pricing ballot initiative, where outside and inside parties spent over $100 million on it. There are very few states that can kind of match the reach of what they try to do legislatively.
Sean, have you seen any studies come out of the state of California to show that, in fact, since pharmacists are being given more credit and more ability to manage patient care, have there been any studies that have shown, because of provider status, that the outcomes are actually better for patient care and for patients?
I would have to look into that, but I'm not familiar. It's not to say there aren't. I'm just not familiar with.
I know
with
as well with oral contraceptives being prescribable by pharmacists now. That's a hot issue in the state of California, and prescribing expanding for pharmacists across the 50 states is a huge hot topic right now in pharmacy law, at least.
Great. So the reason why I asked that question is I'm wondering the roll down with the influence of the state of California, if it's going to help to get provider status at a national level faster than what pace we're at. And what is your view of that? Where are we with the provider status law?
I think the problem you're having at the federal level. Sometimes there's surprisingly little uptake from the innovation from the states, and I think it's just a function of a bottleneck of the healthcare work that they hope to do in Congress. There's so many important issues that they need to get to, and they've really been hung up on the ACA bill now for 7 months, when the goal originally was to do it in January. So everything has been backlogged. The committees of jurisdiction have spent the first 6-7 months on this, and you're left with the difficult reality that they're about to take a lengthy August recess. They'll come back in September. Then they have other issues on budgets to handle with. A lot of these very important issues haven't gotten the attention early on. I think that they need to. A lot of the agencies like HHS and the other agencies still are not fully staffed, not by a long shot, and that is delaying things. I think Mr. Price has made a good start at HHS, but a lot of the positions are vacant, and people are still reevaluating prior administration activities, looking for their own people to bring in. So it's going to be, I think it's going to be into 2018.
So if we come back to Cardinal Health, what specific initiatives are you focused on for Cardinal Health customers that play into government relations?
I think particularly for the customers we have here with us today, obviously following the ACA repeal, advocating for our customers there has been very important. Drug pricing, I think there is a great interest in what the FDA commissioner might be doing with generics, particularly biosimilars. The opioid crisis has hit really every part of what pharmacists do. They see it every day. They are regulated by the states, as are doctors. However, I think you're going to see the federal government perhaps piggybacking on what some of the states do in their attempt to remediate the opioid crisis. That may involve things like additional training for pharmacists on pain management. There's certainly state limitations on the number of opioids that can be prescribed at a time. Our home state of Ohio, by the governor's order several months ago, is limited to 7 pills. That's becoming quite common. PDMPs, 49 states have them, and now Missouri joined this week by
they did.
By executive
Finally.
order. There was kind of a quirky outlier, and I think we're going to build on state initiatives on that issue, and that obviously every one of our pharmacist customers sees that crisis every day.
We're going to have an opportunity during this pharmacy podcast series to have Generation RX on the show in part of the RBC 2017 conference. I'm very interested in that interview to hear how they have set up community pharmacy to really be key players in helping with this opioid epidemic. And if you think of it, they're seeing their patients 10 times more than the physician, and are able, I think, to make a lot more recommendations, including exercising medication therapy management as a part of recovery for these patients.
I think that's right, and I think we all saw and were moved by the video this morning at the beginning of the session,
right,
where one of the patients or the pharmacist talked about his struggle with addiction and how his pharmacist had played a really key role in that. So I think that was a good reminder of just the powerful work that is needed to be done. There's no silver bullet. I think the interview will be very interesting. There's obviously a huge need for at the federal level to provide treatment dollars. Our home state Senator Rob Portman has added $45 billion into the healthcare bill for that, and I think that is a good start. It's I'm glad to say one of the few bipartisan issues on Capitol Hill.
Excellent.
There's not a congressman who won't hear the stories when he or she is out in a district and doing town halls, and I think many of them, their friends, their family are touched by this as well. So it truly is bipartisan. They're looking heavily at providing funding, and at the state level, funding obviously, and education from first grade up, age-appropriate education. Our Attorney General in Ohio, Mr. DeWine, said that is the single best thing you can do.
So you have the audience and the ears of our 65,000 plus listeners out there throughout the country that really tune in to the Pharmacy Podcast. Call to action. What would you like to say to our listeners as someone who is deep into government relations? What call to action, what suggestion can you make to our pharmacist listeners, our pharmacy owners, from a government relations perspective?
I would say, as I would say to any American right now, I mean, the political system this year is very challenging. It's challenging to be positive about it and be engaged, but community pharmacists are a tremendous asset to the community, and I think the elected officials, local, state, and federal, know this. They'll listen to your voice. If you have an issue, work with your trade groups and your community groups. Don't give up on being an active part of the political environment. Small business owners like yourselves are a critical voice in Washington, and a very well-respected community in Washington.
Amen. Sean, thank you so much for being part of the RBC's 2017 Pharmacy Podcast Network coverage here in San Antonio. And any closing words?
No, just thank you for this great opportunity.
Thank you.
Thanks.
Cardinal Health, helping independent pharmacies successfully grow their pharmacy businesses for over 45 years while advocating stronger relationships with patients for healthier communities throughout the country. We thank you for listening to the Pharmacy Podcast live coverage of the Cardinal Health RBC 2017. Be sure to join us next year for the RBC 2018 in downtown beautiful San Diego, California, June 27th through June 30th.